Hello viewers, today I will discuss two of my root canal cases. So as you see in the pre-operative X-ray of this first case, this is the tooth number 46, that is right lower first molar, and if you see the pre-operative X-ray of this 46, you will find that there is a caries present on the distal aspect of the 6 approaching the distal pulp horn. It is very near to the distal pulp horn, this radiolucency, almost involving the distal pulp horn. The mesial pulp horn is somewhat like higher in position than that of the distal pulp horn, which is normal. And if we further analyze the X-ray, if we see the canal spaces in the mesial part, that is in the mesial root, yes, it is visible in the coronal third, in the middle third, and in the apical third. So throughout the length, the canal is clearly visible in the mesial side. In the distal side, that is in the distal root, yes, it is visible in the coronal third of the root. In the middle third is also visible, but it is slightly invisible or not properly visible in the apical third, right? In the apical third. Now, the most important part of this X-ray is you see the sudden drop of the radio opacity from here to here. This region, the sudden drop of the radio opacity in the apical part of the distal root of the 6. Now, at a glance, if you see the pre-operative X-ray, you might think that the radiographic apex of this 6 in the mesial side or in the mesial root is here, which is okay. It is normally if you see the PDL space, it ends here, and the distal root is here. But if you give a close look of this pre-operative X-ray, you will see that the distal root is not goes up to this point. There is a distal curvature, there is a distal sharp curvature which is present on the distal root of this right lower 6. If you track the PDL space, it will going like this and then turns abruptly towards the distal side, then goes like this and then turn like this, and again it will go like this. This is the PDL space. It will go like this. So careful examination of the pre-operative X-ray is very much crucial to manage your case better. Now at a glance, if you see, you will see that there is a root, that the root ends here, but if you give a closer look, you will see the curvature that is present on the distal side of this distal root at the apical third. Now, this is the picture of the master cone selection of the tooth, and if you see here, you can see better that there is a distal curvature present at the apical third of the distal root. Both the canal configuration, that is from distal side and also in the mesial side, is 2-1. That means vertusi type 2 in both the roots. Mesial root, vertusi type 2, distal root, vertusi type 2. Two canals at the orifice and the middle, up to the middle third of the canal, and it become a single canal because of it. Two canals joined each other at the apical part in the mesial root as well as in the distal root. See, if you see the master cone X-ray, you will find that two GPs are going up to this point, and from here one single GP going up to the apical end. Here also, this is the point where two GPs are there, and from this to this, that is from this to this, a single GP which goes up to the apex of the distal root. Now this is the picture of the obturation of that right lower first molar. This is a slight distal angulation picture. So if you took a distal angulation picture like this from this angle, so this one is the mesiolingual, that is the same lingual, this one is the mesiolingual gut aperture that going toward the length, to the full length till the apex, and this is the mesiobuccal one. This one is the mesiobuccal one, this one is the mesiolingual one, because it's taken from the distal side. So the mesiolingual gut aperture extends to the full length from the orifice to the apex. The mesiobuccal, it starts from the orifice and merges with the mesiolingual at the junction between the middle and the apical third of the mesial root of this forceps. Here it merges with mesiolingual. Now on the distal side, yes, 2 GP still here, and then the first GP which starts from the orifice to the apex, its single GP is from here to here. The second GP which I put on the distal side, it goes from here to here, whether the first GP will go from the orifice to the apex. So this, up to this point, there is 2 GPs are there. From this point to this point, this point to this point, the first single GP which reaches the apex is here. Now if we measure the angulation of this distal curvature present in the apical third of the distal root of this forceps, as per Snyder method, where one line we draw straight coinciding with the orifice long way down, and another line coinciding with this line from the starting of the curvature to the radiographic apex. So this angulation is approximately 65 degrees. This angulation is approximately 65 degrees, which I am able to manage in this first molar. Now if you see, this is another angulation of this obturation of this lower molar. It is taken more distally to appreciate the GPs, the gut apertures better, because it is a long way with each other. Now this is the mesiobuccal, merges with the mesiolingual. This is the full length mesiolingual. This is 34, this is also 3004, and here also 3004 GP. Up to this point, 2 GPs are there. From there to here, the single full length GP reaches till the apex. You can see the beautiful obturation of this picture, and this one is the second case. Now before elaborating the case, you can see at a glance the excessive mesial tilt. Excessive, it is not like this, it is like this. Excessive mesial tilt of this molar. Now it is not a 7, because this one is a 6. This is the 6. The 7 is already extracted long way back by the patient. Means patient extracted long way back by a dentist, and this 8 has enough time to shift mesially, or rather I will tilt mesially, to come in contact with the 6. So crown part is in 7. Yes, it is the position of the 7. Root part is in the position of the 8. So it is like this. Now if we analyze the X-ray, yes, there is a distal caries which is present in the 8 on the distal surface. You can see slightly visible pulp chamber space, and a root canal space I am not clearly visible from this pre-operative X-ray. Yes, some amount of distal canal shadow is there. A little bit, but not fully clear. Now you can appreciate there is a curvature present both in the mesial root, that is the probable end of the mesial root, as well in the distal root. It's like this and going like this, coming like this and going like this. Here you can see the curvature, distal, here the mesial. So as expected, there is a curvature present on the distal side and in the mesial side as well, in the apical third of both the roots of this 8, and this is the 2-1 canal configuration. It's same as like previous case. We have to see type 2 canal at the coronal third and the middle third that merges with each other to form a single canal in the apical third of the root. In distal side there is a single canal present. Now this is the master cone of that tooth, of tooth number, it is I think 3-8. This is a 3-8, the left lower 8, and if you see the master cone, this is a 36 and these two are 34% GP. Now this is a mesial angulation picture. I took like this. This is a mesial angulation picture. So this is the same lingual, that is mesiolingual, which extends throughout the length till the apex. This is the buccal, which merges with the mesiolingual at the apical third of the mesial root here, and this is a single 36 GP from the orifice to the apex. Now here I want to say that during a root canal treatment, ideally we should take working length twice, but mostly we took working length once, because normally what we generally do is we take the working length just after the negotiation, that is the initial negotiation of the file. We took the working length by apex locator, but after the biomechanical preparation, whatever the file you are using, maybe it is the super flexible file, some amount of loss of canal length is obviously going to be happen. What I mean is, after your biomechanical preparation, some amount of canal straightening will be there, whatever the file you are using. If it is a super flexible one, then also the chances will be less. Obviously yes, if it is a flexible one, the chances will be less, but practically speaking, minimum will be there, minimum amount of canal straightening also be there, whatever the file you are using. Especially when you are doing a curved cases, ideally you should take working length twice. It is obviously better to take working length twice, before the biomechanical preparation and after the biomechanical preparation. And you should take a master cone adjustment based on the working length which you take after the biomechanical preparation. Now, as per the studies, it has been seen that there is a discrepancy between the canal length before and after biomechanical preparation that ranges from 0.2 to 0.8 millimeter, depending upon which teeth you are doing a root canal and the amount of curvature. Yes, in case of curvature, the straightening effect will be more than that of doing a root canal in a straight cases. So after your biomechanical preparation, remember one thing, some amount of canal straightening will be there. So obviously take a working length after your biomechanical preparation and adjust your master cone selection according to your latest working length, that is after the biomechanical preparation. Now this is the picture of the obturation. This is the distal one, that is the curvature which I am able to manage to obturate, and this is the mesial curvature on the mesial roots of this 3-8. This is the mesiolingual which is going to the full length, and this is the mesiobuccal that merges with the mesiolingual at the apical third of the mesial root. Now if you measure the angulation, it is approximately 75 degrees curvature at the apical third of the distal root of this 3/8 as per Snyder method, where one line which is drawn vertically starts from the mid part of the orifice towards the point B, that is the straight line, and next line coincide with the first line, that is this line. This is the first line which is straight from the orifice way down, and this is the line, this is the second line which starts from the point of curvature to the radiographic apex, and this angulation is approximately 70 to 75 degrees. Now you can appreciate the the proper obturation of this curvature of this case. Now if you found this video useful, so please don't forget to share, subscribe and like the video. We will meet in the next video very soon. Thank you for watching.